resounding agreement here. Overwhelming consensus. Anything else? Yes.
Yeah.
You stood up, so you get priority. You burn more ATP to ask the question.
Yeah, gotta stretch. So I'm thinking about a younger population here, myself, right? Low
about 60. Oh, no, go ahead.
So low ESR, testosterone is great, low CRP. My lipid fractionation is a bit elevated, right? My ApoB is a little bit elevated. I'm wondering how significant really is this for someone who's metabolically healthy, fasting insulin is like 2.5, no insulin resistance, large muscle mass. What do I have to worry about, 50 years down the road if I stay like this?
Well, first question I'd ask you is how old are your parents? Because you got to look at genetics there in terms of longevity. But I'm going to have Christy answer that question. From my standpoint, you go forth and have fun. But I would see what the cardiologist
So
says.
family history is important. Lipoprotein little a, did you get that checked?
It's normal.
It's normal. How old are you? Over 40?
29.
I'm not. So no, I'm saying that in just what we look at basically for calcium scoring.
0.
Is that, well, at age 29, it's a useless test.
Okay.
Pretty much, unless you have FH and you're trying to use, are they high or very high risk? So, this is we don't have simple tests right now. You can do a cardiac ultrasound and look at IMT and plaque. It's probably going to be normal. That just be reassurance with it. You mentioned about some vascular reactivity studies sometimes with it. So where we lack a good test, very early changes of atherosclerosis are difficult to detect. And the problem with ultrasound is it's so operator dependent. 3D ultrasound, Fuster's done some work where if you do 3D in the carotids and the femorals, he did a little bit better for sensitivity picking up in younger people with it. But it's a great question with it right now. And it's easier if someone's later in life with it. That depends how high is the LD or the ApoB. Because that's why they put in Scott Grunny going back, if it's over 190, so that's a high percentile LDL. It's feel like that's going to be the area under the curve lifetime-wise is going to be so high it's worth just starting something. And B is the same thing; it's very high ApoB. But it's a big challenge because the intensity of therapy is dependent upon the overall risk, and all of your other risks are low. Just having one thing up a little bit doesn't really put you in much of a risk category.
Did you say was your ApoB?
ApoB, yeah.
Did you did an expanded lipid?
I did a expanded lipid panel.
What was your particle?
The particle number was about 1,700, 1,800. It's pretty.
High.
Yeah.
That's high.
Yeah. What about your? So it's small.
The small.
70, you should be at your age. You'd be below 1,000.
No. It was higher.
So here's what I would do. You're 29. You're not likely to get structural disease at 29 in your vascular system, but you're very likely to get functional disease. And it's based on your LDLP and your ApoB. So I would measure some arterial studies. I would do the arterial elasticity, C1, C2 compliance. I check your augmentation index, other things that you may not even know because you probably haven't had them done. And then I would stratify you. Yeah, your functional tests are abnormal at 29, so you may need to have that LDLP lowered to keep you from getting problems later. And then you look at your genetics. We talked about that yesterday. Do the cardiovascular genetics and see where you are, if you're ApoC3 or SCARV1 or something else, because you'll miss that totally by measuring HDL because you're not going to pick it up.
So easy genetics. Look at your parents, and if your parents are in their 60s or 70s, see if they've got a big pulse pressure, 70, 80. If they do, I'm sorry. If they don't, there's hope. Okay? Yes?
So the polygenic risk scores also, so in terms of genetic testing, that might be something that also use to give an idea. It's more with your family history. And if though they work pretty well for European ancestry, they don't work necessarily well for everybody.
Yeah.
A number of companies are offering that now.
That's a good point.
So I'm gonna add on you. So I'm him at 45.
I'm sorry.
I gotta stand up, we gotta. So I'm also, I work out, I do my exercises.
So
I try to eat
45,
healthy.
what's your calcium score?
So it's a 0. I got it done recently. I did the arterial study a couple of weeks ago on the YPO event down here that Prolong and some of you guys, other companies that are here, were here. it was negative, but I run over 180 on the LDL, less than 30 on the HDL, and I run over 200 on the total. And I've been doing this since I've been younger than him.
Yes,
But I've never done that one. I've never done the MVP on my parents.
With the 180 and the 30.
And then negative genetics. I've done the 23andMe and another one.
23andMe, I wouldn't go.
Well, I did the YPO one, which was
Get the cardiac.
Med, whatever. And they also told me negative APO3 and negative cardiovascular risk. So my cardiologist, who happens to be Juan Rivera from Hopkins, he's on Univision every day. He tells me I should be on something, but I'll beat him running. I run more than him. I don't know. I'm like looking at him going like, why? So I'm in the same conundrum.
Well, before Christy answers this, let me just give you an anecdote. I had a very good friend. This guy, he played soccer, he ran, he was very physically fit. He was not obese, in fact, he was ideal weight. And at age 54, playing soccer, he dropped dead. And they did a post because he was out, and he had 3 vessel coronary disease. So be careful.
No. I've been getting the studies like the calcium scores, the carotid artery, but yeah, what do you suggest? Like I'm in the same boat 16 years later, but I haven't taken anything. I haven't tried fish oil or anything even regular. I'm just exercising. I thought exercise would work, but it's not working.
By the way, I just want you to know that the meter is running over here. There'll be a bill.
I had it.
Lifestyle is very, very important. It doesn't overcome, genetics completely, so certainly can help mitigate some risk, because even people with unfavorable genetics, lifestyle can lower the risk, but not obliviate it. So it's not only the magnitude of elevation, but it's the duration of elevation. So I'm like thinking of cholesterol years, so how many years you've been exposed to the LDL of 180. I checked your lipoprotein A, because some of that elevated LDL may be unrecognized lipoprotein A. You're not supposed to order this for screening, but it's more for a workup for chest pain. But sometimes in younger individuals who had a 0 calcium score, but I'm still worried, a CTA looking for non-calcified plaque. We don't use CTA as a screening test, but so many patients, they have some chest pain or something, and so I ended up, a 0 calcium score is very reassuring to me as someone who's 70, 60, 70, that's got all those decades without calcified plaque, but someone in their 30s or 40s, especially with high LDL, I'm still worried that the lifetime risk is very, very high. And so I would favor treating. Statins are effective, they're safe, they're cheap, they're generic, and really shifting the curve, because you're not really looking at your risk over the next 10 years. You're looking at your risk over decades. And so your health, now really, if your cardiovascular health now really influences your freedom from morbidity and mortality later in life. And so I would be thinking, the lifetime curves. We know from data from Framingham and other studies that even individuals with mildly or moderately elevated LDL, if they've been at that level for a sufficient number of years, they still have earlier onset of ASCVD compared to their counterparts that have lifetime low LDL. So it's good that your calcium score is 0 in your 40s, but you're still young, and so I would still be worried that other plaques. So you can look for carotid plaque, you can do a CTA. That's not the guidelines don't recommend.
We agree with your cardiologist, basically. but in regards to CTA, you have to ask around. Some people are doing these. You would not qualify for insurance reimbursement with it. The cost may be $3,000 to $5,000 to do a CTA, depending upon whatever they want to charge you, which can be who knows what. Now, there are a few places that will just let you pay out of pocket $500 to get a CTA with it. So you might just, you can get that at some point. Find a good place that's good and it's reputable.
Radiation dose is much lower now.
It's actually a good test. They don't need to charge that much, and it's something that I think in the future may end up being a nice screening test when we have a little bit more data. And also, but you still got to make sure the methodology for reading it, because when they're looking at the soft plaque, there's different software for analysis.
Okay, Christy, okay. We've got limited time. Yeah. Well, okay, he had his hand up and then you go.
Yeah, okay, so, here we go.
Okay, let him go first, and then I'll come back to you. I'm sorry.